At the outset, I thank Mahe University and Dr. Tam Devasi and his team for inviting me for this lecture and this webinar. This is a new topic. Heart failure with recovered ejection fraction is a new topic. As all of us know, heart failure contributes to morbidity and mortality all over the globe, and guideline directed medical therapy and device therapy is actually improving the prognosis and the longevity of heart failure patients. While on guideline directed medical therapy and device therapy, quite a substantial number of people actually recover their LV function and improve. And this particular group of improved ejection fraction is being called as heart failure with recovered ejection fraction. The expert panel of ACC provides the following working definition for HFrecEF. Documentation of LV ejection fraction of less than 40% at baseline with an absolute increase of more than 10% of LVEF with therapy and a second LVEF measurement being more than 40%. If you look at the epidemiology, the proportion of patients with HFrecF varies widely, about 10 to 40%, depending upon the population studied. One of the first reports by Dr. Punos et al. Actually, prevalence of HFrecF was about 34%. And in fact, if you look at the data, 70% of patients actually labeled as HF preserved ejection fraction and documentation of prior HFrecF, that is the heart failure with reduced ejection fraction, suggesting that quite a few of them actually had reduced ejection fraction in the past. Similarly, if you look at the data from Emory University, nearly 16% of the patients with baseline LVEF less than 50% actually recovered their LVEF with guideline directed medical therapy. There is another name, that is HF mid-range EF, which is endorsed by the European Society of Cardiology, a new category of heart failure. And this group is actually a heterogeneous group. Actually, it represents an admixture of both heart failure with reduced ejection fraction who has been treated where the LVEF has improved, and those with heart failure with preserved ejection fraction whose LVEF has actually declined over time. So if we look at the biology of reverse remodeling and recovery of ventricular function, reverse LV remodeling refers to restoration of more normal cardiac myocyte size and LV chamber hypertrophy, resulting in leftward shift of the end-diastolic pressure-volume relationship towards normal values. This is associated with improved myocyte contractility and improved LV chamber contractility. And it is clinically associated with fewer heart failure hospitalization and decreased cardiovascular mortality. And there is direct correlation between the extent of LV reverse remodeling and improvement in cardiac survival. Cardiac remodeling is a dynamic process which can occur in bidirectional manner, both forward as well as reverse. There is a coordinated regulation of multiple molecular and cellular changes that contribute to phenotypic changes in the size, shape, and function of the heart, which actually can result in either improvement or deterioration of clinical status. Basic and clinical studies have shown that many of these cellular and anatomic changes which occur during forward LV remodeling actually start reverting towards the normal, less pathologic phenotype during the reverse LV remodeling, though not complete normally. This to schematically show you that patients with, for example, here you can see with normal heart, with an insult, it could be an inflammatory insult, ischemic insult, or it could be toxic insult or a hemodynamic overload, it remodels. And this remodeled heart, with the constellation of signs and symptoms, we call it as clinical syndrome of heart failure. With guideline-directed medical therapy and device therapy, we can have normalization of the left ventricle over time with ejection fraction fully recovering to more than 50%, or partial recovery with treatment with EF ranging between 40 to 50%, or it may not recover at all depending upon the amount of initial damage the patient had. So if we look at the effect of various guideline-directed medical therapies, that is beta blocker, ACE inhibitor, ARB, aldosterone antagonist, the LV assist device, the the cardiac resynchronization therapy and the cardiac assist devices, they have an impact on multiple levels. At the myocyte level, that is, they can affect the hypertrophy, gene expression, cytolysis can be inhibited, beta adenine desensitization. We are well aware with beta blocker it decreases, the excitation contraction coupling improves, and in fact the aldosterone antagonists increase the cytoskeletal proteins. So similarly, even at myocardial level, the myocyte apoptosis can decrease, the activation of matrix metallus proteinase can decrease, fibrosis will be inhibited, angiogenesis will be promoted, LV geometry changes. So we are all aware that these are influenced by the existing guideline directed medical therapy and the device therapy. Reverse LB remodeling, which occurs with treatment, is not simply a mirror image of the molecular and cellular pathways that become dysregulated during forward LB remodeling. It is a very well coordinated multi-level process that allows the heart to adapt to a new, less pathological steady state. I want you to appreciate that it is not complete normalization, but it is a new, less pathological steady state. So that means the footprints of the initial damage will remain though the ejection fraction normalizes. So what you need to know is there is retention of many molecular features of the failing heart, which can cause a future long-term recurrence of heart failure, even in those who have recovered their ejection fraction. These are some of the common etiologies which cause reversible heart failure. Abnormal energetics is one of the common reversible cause. Apart from that, we know toxic insults, inflammatory diseases, excessive hemodynamic stress, and even excess neurohormone activation can cause reversible. For example, if you look at the toxic insults, anthracycline, the trastuzumab, that is a monoclonal antibodies which are used for the breast cancer, we know that these chemotherapy agents, when instituted for cancer therapy, can cause toxic myocarditis with heart failure. And by withdrawing these medicines, actually the toxic myocarditis reverse LV function improves. Similarly, we know that alcohol-related cardiomyopathy, to significant, almost in 70% of them, it normalizes. Even in peripartum cardiomyopathy, we have a significant reversal of ejection fraction. In fact, it can normalize in more than 70% of them. Similarly, if we look at the immune response, pathological like viral myocarditis, acute lymphocytic myocarditis, the modes, sepsis, these are other situations where immune attack on the heart muscle can weaken the heart, resulting in heart failure, but they do recover with treatment. Similarly, we have the excess neurohormonal stress, the prototype is the Takotsubo cardiomyopathy, and others are the pheochromocytoma, recreational sympathomimetic drugs like cocaine, amphetamines, ecstasy-causing drugs. These also are known to cause toxic injury to the heart muscle, resulting in heart failure, but they all can recover. Similarly, if we have excessive hemodynamic load, for example, is uncontrolled hypertension, severe aortic stenosis, coarctation of aorta. By treating this, there is reversal of heart failure. And other great examples are the abnormal energetics as seen in the thyroid disorders, tachycardiomyopathy in the setting of arrhythmias. These are also reversible heart failures. I'll give an example. This was a 79-year-old woman with breast cancer treated with the trastuzumab, and you can see that the endostolic and systolic frames of LV dilated, where the ejection fraction was 33%. After withdrawal of the chemotherapy agent and guideline directed medical therapy, you can see that normalization of the left function with EF returning normally. It was another case of example, hypertensive heart disease with severe LV dysfunction presenting with heart failure. It was also consuming alcohol. By treating hypertension as well as by stopping the alcohol consumption, that you can see that the endosteric volume recovered, the ejection fraction improved. It is a matter of a year. It went on to have normal ventricle. Is another example. This was adrenal insufficiency with LV dysfunction in young male, and you can see that after replacement therapy with hydrocortisone, the LVEF normalized. So we have many cases. Another example, tachycardiomyopathy with a severe LV dysfunction, severe heart failure, ejection fraction was only 9% in this. This was a it was a atrial tachycardia going on in a 44-year-old male presenting as a DCM. But when we restored the sinus rhythm, you can see that you can see this the M-mode image, how the LV is normalized. And in this individual, if you look at the strain imaging, there was a time lag between the septal and the lateral wall contractility almost to the tune of 224 milliseconds. Immediately after ablation of the arrhythmia, you see that the dysynchrony is reduced by almost half. And these cases actually, they improve over time, rapidly. These tachycardiomyopathy patients actually improve very rapidly. So if we look at the prognosis of these patients, heart failure with recovered ejection fraction, they have a 50% decrease in the hospitalization and better survival compared to those with heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. And even the long-term requirement of cardiac transplant, etc., replacement therapy is also lesser. So if you look at the various data, the incidence varies about 9 to 30% of patients treated with heart failure actually will become recovered heart failure patients. That is the recovered ejection fraction patients. But if we look at the baseline characteristics in these studies, which have looked at the recovery of LV function in patients treated with guideline-directed medical therapy for heart failure, these patients typically have lesser comorbidities. Number one, they are younger, they are having shorter duration of heart failure therapy, and they are having smaller LV dimensions and LV volumes at the presentation, and majority of them are young, as you can see. So to summarize, the predicting factors for LV reverse remodeling in patients with reduced ejection fraction: non-ischemic etiology, shorter duration of heart failure, females, and absence of LBB on ECG. If there is LBB on ECG, if they are on CRT, it's a strong predictor of reverse LV remodeling. And similarly, people have looked at the genetic factors. If there are genetic variants involving structural cytoskeletal proteins or Z-disc proteins, they have a worse prognosis. If they're not involving this, they have a better prognosis. Similarly, if someone has very low ejection fraction, but strain imaging, if it shows good contractility, they have a better prognosis. And similarly, cardiac MR showing absence of late gadolinium enhancement, that is suggestive of scar burden, lesser scar burden has better prognosis. Similarly, biomarkers, if you look at lower NT-proBNP, lower troponin levels, and lower soluble T levels, ST2 levels, lower galactin-3 levels have a better prognosis in the long run with respect to recovery of ejection fraction. What is the natural history of these patients? If we look at the natural history, significant proportion can develop recurrent LV dysfunction, though they have normalization of LV function over time. And this is because the biochemical and the molecular studies done in these patients have shown that there is retention of many molecular features of the reverse remodeled heart. So though the LV starts remodeling, it doesn't normalize. It ends up in a transition zone where there is a new, less pathological steady state. This you have to remember. This happens because of the persistent dysregulation of the transcriptome, metabolome, and proteome of the cardiac myocytes, and the progressive erosion of the native three-dimensional organization of the extracellular matrix. This is the reason why it may not be advised to stop the guideline-directed medical therapy, though there is an improvement and normalization of ejection fraction. How do we manage these patients? Though they are normal with respect to ejection fraction, biochemically and molecular level, they may not be normal. So none of us are aware as on today, management protocol, as we don't have a robust prospective data. If there is persistent exertional dyspnea, JVP, and fluid overload state in this group, we need to definitely look at it and then continue diuretic therapy. If the ECG, if there is absence of LBB, it's a good predictor. But if LBB is there, it's a good predictor for CRT. And in fact, even if you continue guideline-directed medical therapy in patients with LBB, the improvement will not be remarkable until the time you do a CRT. And people have looked at risk of sudden cardiac death in those patients with recovered left ventricular ejection fraction, and they have shown that If there is pathologic mutations in DSP, SCN, 5A, LMNA, FLNC, they are at high risk for malignant arrhythmias compared to other genetic and non-genetic etiologies of TCM. And people have looked at biomarkers level. If there is greater reduction in the proBNP with GDMT is associated with greater improvements in left ventricular ejection fraction, greater reduction in LV volumes, and improved clinical outcomes. And risk of recurrent LV dysfunction actually we can actually analyze in these patients by serially measuring specific biomarkers over time. It's important to measure the biomarkers over time during follow-up. And if you look at the echocardiography, there will be decreased LV and systolic and diastolic volumes, ejection fraction improves, and the functional MR reduces. RV is usually normal in these cases. Though there is an improvement grossly of the myocardial functioning, if you carefully look at the myocardial strain and the diastolic function, they rarely normalize in this group of heart failure with recovered ejection fraction. This is the point to remember. However, if they have higher global longitudinal strain, what has been noted is that the LVF remains stable during follow-up. So if someone has recovered ejection fraction with a good global strain pattern, longitudinal global strain, it's a good indicator of better long-term survival. Similarly, CMR showing the scar burden also has an impact of the recurrent heart failure in this subgroup. They have shown that absence of late gadolinium enhancement, which is suggestive of the scar, is in both ischemic and non-ischemic cardiomyopathy, is a strong predictor of recovery remodeling and is associated with improved prognosis. Similarly, people have also noted with during CMR T1 mapping to measure extracellular volume and interstitial fibrosis is another promising indicator, a predictor of response to therapy and improved prognostication in heart failure. How do we follow up these patients with recovered ejection fraction? It is mandatory that we see them at least every 6 months, especially clinically examine them and do an ECG and do a biomarker evaluation at 6 months. This gives us an idea. If NT-proBNP is elevated, it indicates that some sort of mechanistic stress is there to the left ventricle. So you need to follow them more closely and continue guideline-directed medical therapy in such patients. Echocardiography is preferred at every 1 year. CMR at least once in 3 years. This is to know the scar burden. In some cases where there is genetic cardiomyopathy, in such cases, Holter monitoring is also recommended. So patients with higher risk, that is those with persistent LBB, genetic dilated cardiomyopathies, and those who have higher biomarker profile and more comorbidities, these are the groups who should be selected for shorter interval of follow-up as well as imaging. And you should, in addition, you should also remember that heart failure with recovered ejection patients also can develop coronary artery disease, new onset of atrial fibrillation, which can worsen the existing clinical condition. This is another thing. So treatment of heart failure with recovered ejection fraction, if you look at people who in red heart failure, when they stopped the guideline-directed medical therapy, 40% of patients actually had recurrence of heart failure. So this is a data which has come from red heart failure. Similarly, in another group of toxic myocarditis, when GDMT was withdrawn, there was recurrence of heart failure over time. And this happens in the first few months rather than the first few days or weeks. Cessation of diuretics is encouraged because most of these patients do not require diuretic therapy. And ability to tolerate lack of diuretics is a very good indicator of lower risk of recrudescent heart failure in these individuals. RAS blockade should be continued. In fact, if you look at the paradigm and the paragon heart failure, even mildly reduced heart failure patients also benefit with sacubitril valsartan therapy. Most patients with mid-range ejection fraction, which actually includes the majority of the HFrecEF, in fact, benefit with sacubitril valsartan therapy. Hence, RAS inhibition should be continued in this group, apart from beta blockade. We know that revascularization in the setting of coronary artery disease improves the myocardial stunning and hibernation, and both medical and catheter-based revascularization techniques actually are known to significantly improve the reverse remodeling in patients with chronic IHT and heart failure. And of course, the imaging with CMR and PET, in fact, gives us an idea regarding the viable myocardial segments, which are more likely to improve with revascularization. A word about ICD. Those who are already on ICD, it is recommended that they continue to be on ICD, especially if there are higher risks, such as if there are positive genes for LMNA, SCN5, and FLNC. So, and if they are on CRT, we all of us know withdrawal of CRT in the patients with improved ejection fraction in the setting of LVB causes electrical dyssynchrony and worsening of LV function. So CRT should be maintained in those with people with electrical dyssynchrony, though they have recovered their ejection fraction. Gaps in knowledge and future perspective, if you look at, there are many gaps in knowledge because we don't know about the biology, natural history, and long-term clinical outcomes of these patients because this is a new entity which is being recognized. So to conclude, it is a new designation for heart failure with improved ejection fraction following guideline-directed medical therapy. Though ejection fraction improves, the molecular footprints of myocardial dysfunction actually remain, making them vulnerable for future deterioration. Continuing guideline-directed medical therapy is recommended at present. Follow-up at regular intervals for recurrence is mandatory, but gaps in the knowledge remain, which will be addressed in the near future. I thank once again all the participants in this webinar. Thank you.